Yes, good afternoon. My name is Ali, currently working with CHEP Kenya, where we support clients with HPV, hepatitis B, and HIV, integrating the services under one roof. So today I want to share with you one of the best practices that we did in the year 2024, and it was about breaking the barrier to hepatitis B elimination in urban Africa, which we felt was a scalable model for prevention, testing, and treatment in high-volume public health settings in Nairobi, Kenya. So in my presentation, I have my introduction, methodology, results, lessons learned, conclusion, recommendations, and acknowledgement. Okay. I will be discussing our intervention aimed at eliminating hepatitis B in urban Africa, especially in Nairobi, Kenya. And hepatitis B remains a silent epidemic in sub-Saharan Africa with significant health and economic consequences. Despite the availability of vaccines and antiviral treatments, many communities in urban informal settlement will still face major challenges in testing, vaccination, and treatment access. So a project focused on addressing these gaps by integrating HBV care within existing HIV maternal child health MCH platforms in high-volume public health facilities in Nairobi, Kenya. So the intervention involved a series of strategies, including screening, community-led education, vaccination advocacy, and multidisciplinary team support. Today, I will take you through the baseline data, interventions implemented, and the impact we achieved through this intervention. We will also look at the lessons learned and discuss next step to scale this model for wider use across high burden in Africa. So before we discuss the improvements from the intervention, let's look at the baseline data that guided our efforts. The data highlights the challenges we are facing at the start of the project. So HBV testing and HIV clients, only 34% of HIV positive clients were tested for HBV. ANC attendees, only 28% of pregnant women were tested for HBV vaccination. But dose vaccination, only 19% of newborns received the timely HBV dose vaccination. HIV positive clients, 73% of newly diagnosed positive clients were linked to care, with 58% initiating treatment within 30 days. Among the HIV hepatitis B co-infected clients, only 93% transitioned to TDF-based ART. Okay. Let's now take an intervention implemented in our program. So the flow chart here illustrates how each step builds upon the previous one, ensuring a comprehensive approach to HPV care. So the first step in the process is screening, by targeting key risk populations such as HIV positive clients, pregnant women, and adolescents for HBV screening. And this step helped us identify individuals at risk who needed further care. Once individuals were screened, we implemented point of care testing, and this allowed for immediate diagnosis and real-time monitoring, enabling clinicians to act quickly and provide timely treatment. So this step ensured that there were no delays in starting care. And following diagnosis, we turned our focus to vaccination advocacy, ensuring that newborns receive their timely birth dose vaccination. We also trained midwives to ensure that those vaccines were properly administered, helping to prevent hepatitis B from the very start. Alongside clinicians, clinical interventions, community education played a crucial role. And through peer support groups and caregiver forums, we worked to raise awareness about HBV, encouraging individuals to seek testing and treatment early, and reducing the stigma associated with the disease. Finally, the MDT team, case management team, ensured that patients were linked to care and supported throughout their treatment journey. So this step provided continuous follow-up and ensured that patients remained engaged and adhered to their treatment plan. So this structured approach helps us address each step of HPV care continuum from screening to long-term management, ensuring a comprehensive and effective intervention. So this slide shows our methodology and our timeline that we use to contribute. So it was from January to December 2024, where hepatitis B screening started in January, focusing on HIV positive clans, pregnant women, and adolescents. Point of care hepatitis B surface antigen testing followed closely, allowing for quick diagnosis and real-time monitoring throughout the year. So vaccination advocacy and midwife training activities took place early in the year, ensuring that birth dose vaccination were given on time. Community education and peer support efforts occurred throughout the year with continued education and outreach to ensure engagement in the program. Then MDT case management team for ongoing linkage to care and treatment follow-up happened consistently throughout the year. So data collection for the program was carried out throughout the year, with routine program data being analyzed retrospectively. The analysis was performed using chi-square test and p-values to determine the statistical significance of the outcomes. So these were our results, the post results after the interventions. And in the baseline data, the red bars with the post-interventions outcomes, green bars with the key metrics. So HIV class, the hepatitis B testing increased from 34% to 82%. And C attendees hepatitis B testing improved from 28% to 77%. Birth dose vaccine coverage increased from 19% to 68%. Treatment to linkage, only newly diagnosed HPV positive plants were linked to care, with 58% initiating treatment within 30 days. 93% of HPV co-infected clans transitioned to tenofovir-based ART. So these are the challenges that we encountered along the way, and one of them was the stockouts, which were essential vaccine and treatment supplies. And this disruption prevented timely delivery of HIV vaccines and antiviral therapies, which delayed vaccination efforts and treatment initiation for many patients. So this created gaps in care, ultimately slowing the process of the intervention. Then we also had the limited provider confidence in managing HPV monoinfection. HPV without co-infection was another challenge. Healthcare providers, particularly in resource-limited settings, lack sufficient knowledge and experience in treating HPV independently. And this uncertainty led to hesitation in offering the most effective treatments, which impacted patients' outcomes. Then lastly, we had low community awareness of hepatitis B and its risk in urban informal settlements. So this significantly affected early detection and vaccination efforts. Despite our best efforts through community-led education and outreach, many individuals remain unaware of the importance of early testing and vaccination. So this lack of awareness delayed their engagement with the healthcare system and limited reach of the program. So what were the conclusions? So as we wrap up, our key conclusions and lessons learned from this intervention. First, the integration of HPV care within HIV and maternal child health MCH platforms was a game changer. This approach resulted in significant improvements in testing, vaccination, and treatment uptake, addressing key barriers we identified earlier. This is a scalable model that can be adapted to other high-burden areas in Africa, making it a critical tool in the fight against HPV. Next, the key success factors are peer-led education, which was essential in boosting community awareness, community involvement, and education. And education helped engage individuals who are previously unaware of the importance of early testing and vaccination. The use of digital prompts strengthened the HPV service uptake, ensuring clinicians receive timely reminders for testing and treatment, while which enhanced the overall service. So delivery midwives training played a significant role in improving birth dose vaccination coverage, which is crucial for preventing HPV from the outset. Lastly, the multidisciplinary team approach ensured coordinated care offering patients, consistent follow-up, and structured treatment plan. So the next steps, while the interventions were successful, we must continue to focus on one, overcoming stockouts to ensure that vaccines and treatments remain consistently available, building provider confidence through further training, especially in managing HPV monoinfections, expanding community awareness programs to further reduce HPV transmission and ensure timely engagement with healthcare providers. This model shows how integrating HPV care within existing frameworks can yield powerful results, and we are hopeful that it can be replicated across similar settings to meet HPV elimination goals. So this brings the end to my presentation. Thank you.